My name is Mike Ogonovsky. It's not a classic Welsh name, and I've been heading up Techcomree as a first of all as a small project, but COVID changed everything for that. So next slide, please. And next slide. So just a very quick introduction. Really, we set up Techcomree. I set up Techcomree because there was a real lack of evidence around microservices supporting care and health that we could not identify in terms of efficacy, but we did know that a lot of money was being spent on very small projects that seemed to have potential, but then would die away when the funding ran out. So we wanted to occupy a space within Wales that, number one, helped to provide an evidence base, and if there wasn't one, to develop one. So we have now a research and evaluation framework, depending on the maturity of a given project or product, to support the rapid scaling of technology-enabled care where it's clear that it works, which we'll touch on now with video consultation. But actually, I think it was good to hear as I was listening into preceding talks. It's around supporting culture change, which isn't just about citizens. It's actually about healthcare professionals. Adaptation and adoption is equally important, and to provide, as I said, the evidence base that would support investment decisions, or indeed to terminate investment in any given program that's discovered not to work. Next slide, please. So as we were playing actually with a Scottish instance of a product called Attend Anywhere pre-COVID, looking at its potential use and in prisons, in terms of prison inmates going to outpatient appointments, which has been difficult, care home support for GP out of hours. And also from the emergency department perspective, and speech and language therapy support to care homes as well. Obviously, in March 2020, lots of things changed for all of us, and we were tasked with scaling up a rapid implementation of video consulting capability across Wales, and starting with primary care and a target set for that for 6 weeks. So obviously, understanding that there wasn't the strong evidence in place that this would even work, that professionals would want to pick it up and run with it, or indeed that citizens would, we decided to try and take an agile approach, but really led by the data from research and evaluation that we put into weekly cycles and have expanded as we've gone along. So part of that was actually around the developments of toolkits and information governance, but we asked the healthcare professional and the patient every time the system was used in a very quick way, what they thought about it, whether it was something they would use again, and whether it avoided the need for a face-to-face consultation. And so we'll share some data with you now that has been, some of it expected, but some of it also unexpected. So this is a culmination of around 50,000 questionnaires, which we've been feasting on and continue to use to try and shape our approach with video consultation, but also as an organization. So the first observation I wanted to make was actually that patients in general rated the video consultation experience more highly than healthcare professionals. Some of that was around the difficulties, particularly in the early days, with bandwidth and getting used to using new technology in a clinical setting. But actually some of it was very cultural, and a lot of clinicians reported frustration at having to sit at a screen for a whole clinical session, and that's not really what they went into it for. So there's been some interesting insights from that perspective. Okay, next slide, please. This is really where I wanted to focus around what we've gained from asking so many people and healthcare professionals about what they thought. So in terms of it being able to prevent infection rates, and of course, for a few months, there wasn't an alternative to telephone or video. So scored very highly. But actually, it was reported that they felt it was easier to access care in terms of consultations by video consultation, that they saved on quite a lot of travel and looking for a parking space or having to catch a number of buses to get to a hospital site or a clinic. The amount of time that they would have to take off from work or school was minimized. They felt less stressed and anxious about the appointments, that they felt the environmental impact in terms of the carbon saving has been significant, even for a small country like Wales, that it was a better use of clinical time, that it was more efficient to be able to see people. It also enabled improved family involvement, and this was around sometimes having difficult discussions with patients to allow them to have their relatives, their loved ones, their next of kin, even if they were as far away as Singapore, as we had in one instance that was talked about. It helped us more in terms of minimizing the growth of the waiting times that did happen as a consequence. So where the uptake has been strong in video consultation, actually the opportunity cost has been reduced for having to catch up on elective tasks. And really surprisingly, actually we found that it reduced did not attend rates. So this is where the patient failed to turn up to an outpatient appointment or to a GP appointment. Where they're using the remote care or video consultation in this case, actually we saw a higher attendance rate to those clinics. And of course, then that means less wasted time from the clinician's precious time. We also asked some more socio-economic questions and asked about whether they lived in cities or towns or in the countryside, whether they were considered themselves to be disabled. And also we were very interested in users over 65 years old. And we found actually that this was really helpful data to share back to clinicians who were with very good intentions, assuming that patients over the age of 65 and indeed over 85 would be less likely to be able to cope with video consultation. And this gave us some very strong data that has continued as a trend that actually shows that over 22% over the demographic average for Wales, they're overrepresented. People with disabilities are overrepresented. The lowest income households, so this is under £19,000 a year, were overrepresented. So in terms of digital exclusion, in terms of our assumptions over who would be more difficult to reach, it's really been quite challenging. I won't go into the rest because I know that we're short of time, but just in terms of the challenges, of course, there's been issues with space, access to equipment. So we were particularly in some residential and care homes, even getting Wi-Fi and broadband put in was really important. And we had a program of digital inclusion activity that accompanied the rollout with this. But we also found just access to basic equipment within hospitals and clinics were also a big problem. Some of the stuff that we thought would be a big problem was confidence and perceived competency in using a new media to receive or provide care. And actually that seemed to be a lot less than we'd first thought. Okay, next slide, please. So just very, very briefly, because I know that the interest was in video consultation, we've also been looking at the other elements of technology-enabled care in terms of Telecare and Telehealth. And we've just had a discovery report concluding on the state of the nation, if you like, in Wales. Next slide, please. And what we're finding is a really fragmented approach. So the Telecare is the services that are provided by local authorities, social services, if you like, across Wales. And so these are led by councils and not health boards. And those two are not coterminous. So one health board can have as many as 7 local authorities. But there are 77,000 existing Telecare users in Wales, and 91% of those are over 65. So again, even if they're quite simple devices and call centres, the usage is within the elderly, as we'd expect. But the variation that we found in service provision, as well as in the costs that are charged or levied to the authority or to the individual, was remarkably different. And there was absolutely minimal integration with health services. So in terms of the case for prevention, in terms of the value proposition of Telecare and indeed of care services, we're going to be carrying out some research in terms of the benefits to the health system, as well as obviously to the individual. I think that's the end. Next slide, please. And there we are, just contact details. Thank you very much.